Hello, my name is Dr. Yelena Janjigian. I'm a medical oncologist and chief of GI oncology service at Memorial Sloan Kettering Cancer Center. Today, we're discussing biomarker testing and associated targets in esophageal and gastric adenocarcinoma and application of emerging new therapies in this field. Patient 1 is a 64-year-old man who presented to a clinic with known diagnosis of stage 4 G-junction adenocarcinoma with biopsy-proven metastasis to the liver. The patient was initially diagnosed when he presented with 6-pound weight loss, difficulty with certain types of food. Otherwise, he was relatively asymptomatic, feeling well, and continuing to work full-time. So when you see this patient in clinic, radiographically, often there is 2 decision points that you need to make. Is the disease burden large enough for combination therapies? What are the biomarker testing that needs to be done in clinic? The typical diagnosis of these patients is made on endoscopic biopsy. So there is plenty of tissue obtained for biomarker testing, and we like to get unstained slides for the testing, often 5 to 10, sometimes 20 slides or tissue block. So what are the important biomarkers in this setting? All patients in stage 4 disease, and I would argue even in more advanced resected disease, need to be tested for HER2 as there's validated biomarker. MSS and MMR testing is needed by immunohistochemistry and PD-L1 testing. The emerging immunohistochemistry testing include FGFR2b and Claudin 18.2 protein overexpression, although those tests are not still yet considered standard, and those clinical trials are in phase 3 setting. So if we do have bemarituzumab, which is an FGFR2 antibody, and zolbetuximab, which is a Claudin 18.2 antibodies in clinical practice, you should be aware of those tests and order them as well. In addition, often in first-line setting, it's very helpful to initiate next-generation sequencing, in-depth analysis of the tumor and matched germline analysis to understand if there's other potential targets that are emerging, such as NTRK, which is very rare but does occur, and entrectinib could be a potential targetable therapy, and as well as other emerging targets such as EGFR amplification with some early preliminary efficacy data. So in summary, biomarker testing for this patient would be critical. We would start testing for HER2 and MSI and PD-L1, often in parallel or before we start systemic therapy. And first-line combination therapy with FOLFOX and nivolumab is standard in this patient, irrespective of PD-L1 status, although we know that high PD-L1 overexpressing patients benefit the most.